Hello everybody, now we will read about polycystic ovarian disease or polycystic ovarian syndrome. PCOS or PCOD is the single most common heterogeneous and multisystem endocrine abnormality of women of the reproductive age group and is the most common cause of secondary amenorrhea. It is characterized by menstrual irregularities, hyperandrogenism, obesity, and polycystic ovaries on ultrasound. It was discovered by American gynecologists Stein and Leventhal in 1935 and hence was called Stein-Leventhal syndrome. In the past, incidence. Worldwide incidence is 6 to 10%, being more common in infertility patients. It is becoming more common due to change in lifestyle and increasing stress levels. It is also becoming more common in adolescent girls, often developing soon after puberty. Now, diagnostic criteria. In 2003, a consensus workshop of PCOS sponsored by American Society for Reproductive Medicine and European Society of Human Reproduction and Embryology in Rotterdam, a city of Netherlands, stated that 2 of the 3 criteria should be present to make the diagnosis. These are called Rotterdam criteria. Rotterdam criteria for diagnosis of PCOS. First, oligoovulation and anovulation. Second, clinical or biochemical signs of hyperandrogenism, that is excess androgen activity. And third, polycystic ovaries on gynecological ultrasound, 20 or more follicles measuring between 2 to 9 mm in each ovary or ovarian volume of more than equal to 10 cubic centimeter. Now, the clinical features of polycystic ovarian syndrome. First, hirsutism or male pattern balding consistent with hyperestrogenism. Second, irregular or absent menstrual cycles. Third, supertility or infertility. Fourth, psychological symptoms like anxiety, depression, psychosexual dysfunction, eating disorders. And fifth, metabolic features like obesity, dyslipidemia and diabetes. Pharmacotherapy. Treatment of irregular cycles and hirsutism. Wait minimum 6 months for response. First, combined oral contraceptive pills. It is the first line pharmacotherapy in adolescents PCOS. Low dose estrogen 20 to 30 microgram ethinyl estradiol containing OCPs are preferred. The 35 microgram ethinyl estradiol plus cyproterone acetate preparation should not be considered first line in PCOS due to adverse effects including venous thromboembolic risk. Second, anti-androgens. If OCPs and metformin have failed to improve outcomes in androgen-related alopecia and hirsutism. Spironolactone androgen receptor blockade to 200 mg per day in 2 divided doses. Cyproterone acetate androgen receptor blockade used with ethinyl estradiol as an OCP. Flutamide, competitive inhibitor of androgen receptor, 125 to 250 mg twice daily. And finasteride, 5-alpha reductase inhibitor, 5 mg per day. Now, treatment of insulin resistant. Metformin. It should be considered in women with PCOS with BMI more than 25 mg per meter square. If diet and OCPs has not desired effect. Greater benefit in diabetes risk factors, impaired glucose tolerance or high risk ethnic groups. Metformin lowers blood glucose by inhibiting hepatic glucose production and enhancing peripheral glucose uptake. Start a low dose with 500 mg 1 to 2 weekly and extended release preparation may minimize side effects. Now, treatment of obesity. Lifestyle modification and metformin used. Orlistat and sibutramine can be given to women with BMI of more than 30 if above fail. Thank you for listening. Thank you.